Hello and welcome to this short talk on doing safe sedation in district hospitals. Now, sedation is a key part of procedures done in district health facilities, and often they're done in very difficult circumstances with resource restriction. They also represent an opportunity to improve the environment that you work in and those systems that make these procedures safer. So I'm going to be talking a little bit about that. Further, they provide an opportunity to improve skill sets. So where possible, you need to try and bring inexperienced and experienced people together when you're doing sedation. They often provide opportunities to learn things like how to keep an airway open, how to monitor someone's respiration, how to do bag mask ventilation. Also, appreciate these guidelines, which are released by SASA, and they are relevant to 2020 to 2025. And they are accessible, very good definitions. They provide a nice set of guidelines around doing these procedures, and they're worth a read. Now, some of the principles I think are important. It's a myth that sedation is easier and safer than anesthesia. As a specialist anesthetist, when I have to allocate anesthetists to various procedures, I send junior anesthetists to do full anesthesia, and I send seniors to the ward to do the sedation. And the reason for that is that I consider sedation harder than anesthesia because of the environment that you work and the lack of equipment and the fact that often you don't do definitive airway management. So don't think I'll just take the easy way out and do sedation. You need to take it very seriously. Recognize when you are thinking, I hope I can get away with sedation. That sentence, when you say it, is telling you that you need to be in an environment where there's help and there's lots of equipment and monitors. When I start thinking, I'll see if I can get away with it under sedation, my own message to myself is perhaps I need to take this patient to theatre and do it with appropriate staff. And finally, when you're doing sedation, stick to what you know. So I'm going to be talking about routine drugs that you have available and will have worked with. It's not the time to experiment with drugs you've never used. You want to do that in a supervised setting or at least in theatre. So I won't be talking about dexmedetomidine, which is Precedex, or novel ways to use droperidol for sedation. I'm going to be talking about the simple drugs today. Now, sedation is a continuum, and whenever we look at what level of sedation we are talking about, we look at four main indices. How responsive is the patient? Is the airway maintained? Is the patient likely to breathe on their own? And how is the cardiovascular function affected? And as you move from minimal sedation to moderate sedation to deep sedation and then to general anesthesia, each of these variables change. And so with increasing depth comes increasing complications, increasing likelihood that the airway will need support, that the patient may stop breathing, and that the cardiovascular function will be affected, and also that your patient will be less responsive to you as you get deeper into sedation. So the level that you're aiming for will dictate what staff you need present, where you will do the patient, and what complications you can expect. And the hard thing about sedation is it's not always easy to keep them in one column. They move between these different levels of sedation as you change stimulation and as you give them different amounts of drugs. So it's important to think, which type of sedation am I doing? Am I doing basic sedation or am I doing advanced sedation? Some of the differences: with basic sedation, you're using generally one agent. This is basic sedation. You can actually do the procedure yourself and the sedation. Advanced sedation, you shouldn't. And there you're using two agents like a benzo and an opioid, or you're using something like an induction agent. And that would include propofol and ketamine. If you're using those agents, you're actually doing advanced sedation. For basic sedation, you can use clinical monitoring, perhaps a SATS probe, but you can actually just talk to patients, and that's enough of a monitor. For advanced sedation, you need lots of monitors on the patient and ideally a fasted patient. Basic sedation, you can do the procedure and the sedation. I know this happens a lot, but if you're doing advanced sedation, you need a separate person to watch the sedation, which I've labeled a sedationist. And that's just someone who's not looking at the procedure, they're looking at the monitor and the patient for you. And it doesn't have to be an anesthetist, it just needs to be someone who can appropriately assess a patient's level of sedation and their ability to breathe and let you know if you are doing the operation that there's an issue. Basic sedation can be done, it's generally conscious or very light sedation can be done in the ward. But if you're going to go into that deeper or advanced sedation, you generally need to either be in theatre or you need to be really set up in a procedure room or wherever you decide to do it. Some of the things you need to consider whenever you think that you're going to do sedation. The first one is, what procedure am I doing? Is it sore? Is it easy? Is it likely to complicate? Is this a small thing like a bone marrow biopsy, or is it a big thing that could go wrong? And depending on the procedure, that alone might dictate what resources you need. The second thing is, how sick is my patient? Is there anything unusual? Is this a well, fit, fasted patient? Is this a pregnant patient or someone who uses drugs or has got a depressed level of consciousness or is very old? You need to assess your patient and say, basically, how sick does this patient feel to me? And then the third aspect is, where are you thinking to do this procedure? Based on the procedure and the patient, what environment do I need? What monitoring and staff do I need? And what's my plan B? What will I do if things go wrong? And even though we plan for the things to go well, or we hope for things to go well, we need to have a plan for if things go wrong. And you don't want to be in the ward when things go wrong on a procedure for whatever reason. And so the likelihood predicts the environment you must use. And when you look at the procedure, the patient, the environment that you're in, that then tells you, what sort of anesthetic can I do? Can I immobilize? Can I make this patient unconscious? What analgesia can I use? So your method is going to be dictated to some degree by where you are, what staff you have available, and what your plan B is. So just quickly on your patient, remember that if you're doing sedation for things like evacuations of uterus, there's always a sick patient on your list of 5. You just don't know which one it is. So look at simple clinical things. What's the heart rate? What's the blood pressure? The respiratory rate is a lot more important than people realize. It's the second biggest predictor of outcome when you get to a patient's bedside. Are they breathing fast? You'll often underestimate this. So get into the habit of actually timing this with a watch, 30 seconds to a minute. And then what is the level of consciousness, the Glasgow Coma Scale, but just what is the level of consciousness? And that is the number 1 predictor for outcome. So respiratory rate and level of consciousness, very important predictors in how sick a patient is. You don't need lots of investigations, but a ward hemoglobin is quite useful. And when you see that it's really low, maybe you need some more. Obviously, the patient's comorbidities and things might tell you otherwise, but usually a ward hemoglobin is a minimum. And then are there other things that you haven't thought about? Elderly patient, obese patient. What's your gut feel? Does the patient feel sick? And you should get into the habit of listening to that gut feel. If they feel sick, if you've got that worry about this procedure, go to an environment like a theatre. You can still do the sedation in theatre, but just be where everything you need is. Think about the procedure. Is it sore? Is it easy? How much sedation am I likely to need? As an example, when you're think about how much stimulation is from the procedure. So how sore is it going to be? How uncomfortable is the patient? And how much sedation will you need? And you're always balancing the amount of stimulation with the amount of sedation. So if you think about an evacuation of the uterus, that is a procedure that is uncomfortable for the woman, partly because of the position she'll be in. It's uncomfortable because of what we're doing. It's not sore in the way that a laparotomy would be sore. There's a deep visceral pain. And so they will need some sedation and something for the pain or the discomfort of the procedure itself. So both elements will be required there. Compare that to something like an intercostal drain insertion, a chest drain. Now this procedure is primarily a painful procedure. And if you get your local anesthetic correctly done on this procedure, you actually don't require any sedation. So this is a procedure that's dominated by stimulation and doesn't require much sedation. Occasionally we do give a little bit of sedation, but mostly this is about getting your local anesthesia right, in which case these things can be almost pain-free and actually well tolerated. So the procedure dictates the recipe that you choose. The environment, How do we make decisions about the environment? What backup do you need? What's your plan B? The theatre versus a ward. And just think, if you have to manage an airway and you're in a cot bed, how difficult is that going to be? The patient starts bleeding unexpectedly. How are you going to manage that? And if the procedure is a straightforward one, you wouldn't take a bone marrow biopsy patient to theatre routinely, but if it was a very sick patient, you might. So all of these things factor into your decision about where you're going to do it. Use sedation to set up your environment better. So theatre is obviously one thing, but if you're going to be in the ward, district hospitals can do this. You get one trolley where you basically set that trolley up for sedation. You call it your sedation trolley on it, and it's got your equipment like a spare supraglottic airway. It's got endotracheal tubes. It's got the various paraphernalia you will want to put your drips in, and maybe some of the common drugs you'll need. On that trolley, you stick a multi-parameter monitor, if you can find one, ideally something with a heart rate, a blood pressure, and an oxygen saturation. And this one there has got capnography. Remember that if you do want to use capnography, you also get these smaller, cheap ones. And capnography is quite useful if you're doing deep sedation, but my suggestion is if you're doing deep sedation in the district areas, that you try and get to theatre if you can. If you can't, then you need to be able to do this, and obviously include things like airway management equipment. And finally, staff that are familiar with sedation are very, very useful. So if you are doing something a little bit more advanced in a ward setting, get the nurses that understand what the procedure looks like, get the more experienced doctors within your group that understand these procedures just to come and watch the sedation for you. It's often a quick thing. You set it up, they walk in while you do the procedure, and they walk out again. But having experienced hands is very, very useful, and it's worth thinking about. The principles of the actual titration of sedation, so the delivery of sedation, is that titration eliminates guesswork. What this means is that there's a lot of inter-individual variation between patients, and you don't know whether they need 1 milligram of midazolam or 5 or 15, and everyone responds differently to it. So that's why it's important to not have a fixed dose for sedation, but rather give a small dose, see how the patient responded, and repeat it often. So be patient, use small doses, and use multiple doses. This is a much better idea than pushing in 5 milligrams of midazolam to someone who's very sensitive, and suddenly you've got an unconscious patient and you're in an unusual situation. So I give my drugs generally one at a time. I titrate to effect. I watch how the patient responds, and I give the midazolam dose until I reach an endpoint that I'm happy with, and then I'll give the other drug around the procedure. So I never have a fixed dose for any one procedure. I use the patient's response. Remember that sedation is not analgesia. I'm going to come back to this, but if you're hurting someone with the procedure, either with a blade or with the manipulation of a bone, the answer is not to give more sedation, it's to give more analgesia. If a patient is anxious but they're not sore, then the answer is to give more sedation. So think about what the thing that you're trying to treat is. And then remember that restless patients need attention. We often think, it's just the midazolam or it's the agents that I've given, but sometimes these patients are hypoxic or they're obstructed, there's something wrong. And so if a patient becomes restless, everybody stop and say, what is the cause of this restlessness? Look at the vital signs, look at how the patient's clinical scenario is before you say, it's just disinhibition from midazolam. So pay attention to restless patients. Now, I've talked about giving local anesthetic. Remember that nerve blocks are very, very useful. And I'm not going to get into those today, but it is worth knowing nerve blocks, because if you are good at that, you can remove the stimulation completely. You can have a completely pain-free procedure, and maybe you don't need the sedation. And if you've got a working block with no sedation on board, you don't require a separate sedationist. And you'll see this in the United Kingdom, people doing shoulder replacements completely under brachial plexus block. Patients wide awake listening to music while someone replaces their shoulder. So this is a skill that's worth developing, and use these whenever you can. If you can't do the block, at least use local infiltration wherever you can. And just as a reminder, these things are easily learned these days. This is one of the websites, NYSORA, which is the New York School of Regional Anesthesia. They've got an app, and they'll show you the written way to do the block, nice pictures, all the anatomy for your revision, and then videos of these things actually going in. And if you can get access to an ultrasound, these blocks become very, very easy. So this is a skill really worth looking at, and one which I'll cover in a different talk. Just some notes on reversal. I've noticed the practice that many people are giving benzodiazepines and then reversing with flumazenol at the end of the procedure. I don't advise doing that. It shouldn't be routine. If you are going to do it, you need to know the half-life of the drugs you're using. And the half-life of flumazenol is less than 1 hour, whereas the half-life of midazolam is 2 hours and diazepam even longer. So what this means is that you're going to give a benzodiazepine, you're going to then give your flumazenol, they're going to wake up beautifully, and then they are going to go back to sleep in an unmonitored setting once they have left the ward or climbed on the minibus or wherever they've gone. So think very carefully before you use these drugs. Same with naloxone. The half-life is 1 hour, whereas the morphine half-life is 2 to 3 hours. So depending on the agent that you've used, you may find that both your benzodiazepine and your opioid kick back after you've used these reversal drugs. So make sure they're going to monitored settings if for some reason you use these drugs. And finally, think about discharge criteria. So when can you walk away from the patient? And in general, you want them to be able to protect themselves. If a blanket or a pillow falls across their face or they get airway obstruction, are they going to be able to look after themselves? And if you feel like they aren't, they really need to be in some sort of recovery room scenario where they're monitored and there's someone who can respond to monitors. And just as an aside, if you're doing sedation in an outpatient procedure, remember that some of these patients then climb into their cars and drive home. They shouldn't really do anything like that for 24 hours, so you need to think about how they're getting home. Now, finally, I'm going to just finish with some general principles of recipes. We've talked about how you will want to deal with stimulation, so think about them separately. Something to deal with analgesia, start with, can I use a local anesthetic? So infiltrate with either lignocaine or bupivacaine. Field blocks, nerve blocks, or just local infiltration. And then if you need to, supplement with an opioid, and there's agents like fentanyl, pethidine, morphine. Fentanyl works the quickest. It's got a high ceiling, so it's very effective, and it lasts 20 to 30 minutes. Pethidine works within 2 to 3 minutes and will last for something like 2.5 hours. Also an effective agent, but does cause some euphoria. And morphine, probably the least effective of these three, starts working after longer, works for longer, but for many people it's the analgesic that they'll use. I tend to use the shorter acting agents when I do sedation. For sedation, use a benzodiazepine. That's what most people are familiar with. The official dose of midazolam is 0.1 milligrams per kilogram, which means 6 to 7 milligrams in a normal person. What I do is I mix the midazolam up 1 milligram per mil, and I literally start with 1 milligram and I watch how the patient responds. And I get my sedation in first. So I'll start with the midazolam. I'll titrate it in until I see the patient is relaxed and maybe just falling asleep, and then I add the analgesia secondary to that. So I don't give them both at the same time. I titrate the one in and then I titrate the other, depending on whether it's going to be a procedure that requires sedation or analgesia dominant. And finally, there's ketamine. So ketamine gives you sedation and analgesia. The simple way to do it is just to give a 0.5 milligram per kilogram bolus and repeat that bolus in a titration. I'm going to just come to ketamine in a different slide, but remember we're trying to balance sedation and analgesia, and ketamine just does both. So it's not an elegant drug, but it will give you both elements. And, it's a pretty safe drug if you feel like you're a beginner. So with ketamine, the way that I give ketamine is I titrate my midazolam in first, always give a benzo with it just to smooth it out, prevent some of those hallucinations. That dose ends up being somewhere around 2.5 to 5 milligrams in total. I add glycopyrrolate, 0.2 to 0.4 milligrams, because ketamine causes quite a lot of secretions, and this dries them out, gives them a tachycardia too. So just be aware of that. And then I titrate my ketamine in on the background of having put my midazolam and glycopyrrolate in. What I do is I give boluses of 0.5 milligrams per kilogram IV as they need it. And that's pretty much my standard recipe. Sometimes if you've got a pediatric case and you're struggling to get near the child, I'll give a 5 milligram per kilogram IMI bolus into the buttock. And you let the child then just sit with the mom until they start to become sleepy. Then you can put up a drip and you can do as you will. And some people run infusions of ketamine at 2 to 4 milligrams per kilogram per hour. Bear in mind that's an anesthetic dose of ketamine, so that's for doing in a theatre. And in general, ketamine should probably, if it's easy enough, it's best to do these in a theatre. But what you should do is that if you're going to do this recipe that I put in front of you, is you need one person to do sedation and one to do the procedure. Finally, there's Ketofol. I'm always asked about this. This is a combination of ketamine and propofol, which enables the use of lower doses of both drugs, minimizing adverse events like respiratory depression. The suggested dose in the SASA guidelines is a 10 to 1 mix, so 10 milligrams of propofol to 1 milligram of ketamine. You get the greatest benefit for continuous intravenous sedation in adults undergoing surgery. This is a very useful drug, and I do use it. And people play with all sorts of ratios, 5 to 1, 1 to 1, depending on what they're trying to do and where they are. But just bear in mind that as soon as you are touching propofol, you should be in theatre with monitors and the ability to manage the airway, because these patients do sometimes get apnea. So that's the principles. That's the approach to sedation. I think if you follow those, you'll end up doing it safely. And then if you want guidance on specific procedures, in general, look them up. Or, of course, you're welcome to contact me. Thanks.